The Human Genome Project was a 15-year study which mapped all of the human genes, or the human genome. Since it was completed in 2003, knowledge and technology has advanced rapidly. Scientists have made great strides in understanding how changes in our DNA can affect how the cells in our bodies work and cause diseases like cancer. This is called genomic medicine. The hope is that by finding out more about these genomic changes, we can develop a better picture of how diseases affect individuals differently and provide treatments that are more appropriate to their condition. This is called tailored treatment. Cancer researchers are studying how these genomic changes can cause damage to cells and the way that they grow, and cancer can develop as a result. And cancer-causing genes can be inherited from our parents, but changes in our DNA that can cause cancer are more likely to develop during our lifetime, for example, because of exposure to substances like tobacco smoke. Scientists and doctors are researching how these genomic changes cause cancer, and they're using this knowledge to develop new tests and therapies to improve how we prevent and treat cancer. And one way in which they're doing this is to look at the whole set of DNA, or the genome, of people with cancer and to compare it with the DNA, or the genome, of their cancers to pinpoint these genomic changes. And in the UK, the 100,000 Genome Project is an example of this kind of research. As part of this, scientists and doctors are analysing the DNA of cancer patients, and it's hoped that by the end of that project they will be able to use this genetic information for each patient to tailor their treatment, to use therapies that are better for their kinds of cancer. As sociologists, we're interested in what this research means for cancer patients and their families, as well as the researchers and the healthcare practitioners who are working in this area. There are lots of questions here about how this research and the changes it might bring to cancer care will affect people's relationships, their responsibilities and their identities, or their sense of who they are. And these changes will not just affect patients and their families, but they'll also affect professionals involved in their care. So as part of this, we're interested in what it means for scientists, for doctors and nurses, especially how they work together and involve their patients in the research, and what kinds of changes they think it might bring for patients and their families. So to find out more about this, we went to speak to some of the people involved in the 100,000 Genome Project, mainly colleagues involved with the Yorkshire and Humber Genomic Medicine Centre in Leeds.
There are many potential benefits of genomic medicine for patients. There was a paper came out from NHS England last summer entitled Improving Outcomes with Personalised Medicine, and that outlined what they described as the 4 P's of personalised medicine, which goes hand in hand with what we're talking about here in genomics. So the first P is prediction and prevention. So by doing whole genome sequencing early, we will hopefully be able to pick up patients at risk of a particular disease, and it might be that preventative action in that case doesn't even need drug intervention. It could mean a change in lifestyle. More precise diagnoses is going to be absolutely critical, particularly in cancer, for providing correct treatment for patients. The third P is personalised treatment, so trying to get away from that one-size-fits-all, so everybody diagnosed with the same cancer gets the same treatment. So there's some of that going on already, where patients have particular gene testing to see whether or not they're going to be sensitive to a particular drug if they have a particular mutation. Whole genome sequencing obviously takes that much wider, and treatments will be based upon your genomic diagnosis rather than your presentation. And the fourth one, which I think is critical and will be a big change for the NHS, is the patient participation, the patient's ability to get involved and to be able to have the discussions with their clinicians about their lifestyle, their genomic sequence, what changes they can make, environmental factors, so that the whole thing will come together and make patient care much more tailored to the individual.
The Genomic Medicine Centre is very important because we have a number of molecular tests in routine practice across the National Health Service at the minute, which look at single genes usually, which are small regions of the patient's genetic makeup within the tumour that, if you have specific changes in, might make an individual patient more or less likely to respond to a specific treatment. But we know that we can get much more information out of a patient's cancer than that, and we can actually look at much larger panels of multiple genes, so looking at different changes within multiple regions of the patient's genome within that tumour. Or in fact, we can even look at now the whole genome sequence and look at the overall makeup of changes across that patient's individual cancer genome. And of course, all patients will have a completely different makeup of their cancer, even within a single cancer type. For example, no breast cancer is the same as another breast cancer. There'll always be individual changes within the genome specific to that patient's tumour that might give them a better or a worse prognosis than others, and might make them more or less able to respond to different treatments. And by developing a genomic medicine centre, we can introduce these more advanced technologies with the support of a bigger team to integrate that care into the patient pathway.
For cancer, it's in the first instance certainly about looking at therapeutic options, and increasingly therapies need to be targeted to either work with or against mutations, so it's really important to know what the specific nature of that tumour is so that you can target appropriate therapies. I mean, we don't want to be giving people therapies that aren't going to work because of the implication for them with these potentially toxic therapies, but also, you know, there's a health economic model that we've got to address here with an ever-increasing living with and beyond cancer population, and best applying the limited resources we have to appropriately targeting their treatment.
We know from other sociological studies that this kind of personalised information about cancer also brings lots of questions for patients and their families, especially in relation to what to do about that information. For example, sociologists have researched how family members respond to information about whether or not they or members of their family have a gene called BRCA, which heightens the risk of breast cancer or cancer of the ovaries. And we know from this research that although some people welcome this kind of information because they can make changes to reduce the risk of cancer, others find that the information can bring uncertainties about who to tell or what to do, bringing new responsibilities to people for their and their family's health. So this means when thinking about how patients and families might experience genomic information in the cancer clinic, we need to be aware of the different kinds of certainties and uncertainties that it might bring. We also need to be mindful of how people can deal with the responsibilities that come with this information differently. And this is something that the doctors and scientists and nurses that we spoke to are also concerned about.
I think many of the challenges we've experienced to date, there's a multitude really. I think being able to appreciate just the breadth of what we have to put in place, and that's literally from the point of diagnosis of suspected cancer in patients right the way through to how we're actually making treatment decisions with patients, understanding how best we do that, understanding what that might mean for patients, and clearly that's one of the areas we're particularly interested in. How do people with cancer respond to that kind of information? How do they help to make sense of it? So it's about processes, it's about managing IT and information, but also it's thinking about how do we actually have those conversations with patients and how do we help them make informed decisions based on things that are quite complex really. The second main challenge is considering how we have these conversations with patients. How do we help them to understand the significance of what they might be consenting to within the project? How we help them make that informed decision for themselves, because there's consequences in terms of that information for themselves but also for their families, and I know that's one of the concerns some people will express. what we do with that information, how we process it, how do our clinicians feed that back? Because a lot of the services at the moment are done by specialist geneticists. And part of what we want to be able to do here is help clinicians that are treating them with a particular specialism to understand how to do that. So there's a lot of mainstreaming that needs to go on, as well as supporting patients.
The biggest challenge of all is how that data will ultimately be used for the benefit of individual patients. So we have a very large data set potentially in the NHS, NHS England. That would be a potential data set encompassing 40 or 50 million people with genomic data for many of them, a lot of data on their clinical care, their treatment and so on. So that is a very, very powerful tool, but it still relies on being able to use it. It's not much use if it's just sitting there. And so a big challenge will be developing the systems of interrogating this data set so that the individual clinician with a patient in front of them will be able to use that to direct the patient's care and management.
We all know that the NHS is under incredible pressure. It works to maximum capacity, there's time pressures on staff. Trying to bring in what is going to be a completely new way of working is an incredible challenge. Overcoming people's perceptions of what that future is going to look like, what it's going to mean for them, what it's going to mean for their patients, again, is a huge challenge. From the patient side and the public side, really, creating awareness and those involved in the project managing their expectations of what the results are going to mean for them and being clear about what those results are going to mean for them, either now or in the future. For a lot of patients taking part in the project, particularly the cancer patients, they will be going down the same treatment route that is in place at the moment. It'll be future cancer patients that will benefit from the data coming out of this project and the results that we can get from it.
We're also interested in the wider changes these developments might bring, including to how the health service is organised and what this means for staff and patients. And doctors, scientists and nurses have told us that genomic medicine has the potential to radically change how healthcare is provided. So the 100,000 Genomes Project is not just an important piece of research, it's the beginning of a new way of delivering healthcare.
I very much see genomic medicine as a pathfinder. So when we talk about personalised medicine, the future of personalised medicine doesn't necessarily need to mean genomics, but actually what I see is that it's in the genomics field where people are learning how to think like that, how to adapt it and how to apply it. The 100,000 Genomes Project is very much a hybrid project of both research and clinical transformation, bringing the two together. And actually, I think that particularly in genomics, it's easier to see how that's working and why that is so important. But actually in the longer term, it's this idea that you bring both sort of clinical and research much closer together will perhaps possibly even be the bigger impact. So I see it as important in its own right, but important as a trailblazer towards that sort of more integrated approach.
The reason why NHS England have embarked on this project is because genomics medicine is seen as effectively one of the main themes in the future of medicine as a whole, and possibly it's a little bit misleading because people think it is related to these very rare groups of patients and so on, but actually in reality genomic medicine will cover a very large chunk of all aspects of medicine in the future.
I think for me one of the main things that the GMC is trying to set up is a pipeline through which samples and data can be got from the patients to be put into a resource where whole genome sequencing can be done, there can be levels of analysis, there can be checking of all that data, and then back out through those pipes, through the clinical teams and back to the patients. So this is the whole NHS essentially working together to set up that pipe work that will allow industrialisation of genomics and delivery, I think, going forward. And I think making sure that those pipes go out to all of our clinical teams to make it possible to access all of our patients across the region for the whole range of clinical specialism, I think is the key thing that we're trying to achieve here.
Why is the NHS an important ingredient into this? Well, this isn't purely a research project. So really this is world leading in the way that we're drawing patients from routine care and finding solutions for them. You can only do that through the clinical pathways that we're utilising. So I think the NHS learning how to come to grips with the high quality of samples that we need, along with the linked data, and be able to consent patients in a very complex agenda that many people don't understand what genomics is. But if we do this and we practice and we learn how to do it, then when we commission this in the very near future as part of routine care, the NHS will be able to deliver.
Transformation on this scale brings with it many challenges for professionals working in the health service. This involves new ways of working and involving patients in research too.
There are practical challenges about making bits and pieces work. You know, we've got a huge area to cover, we've got lots of clinical teams. Everybody is very keen to get engaged with this, but of course we're trying to actually embed this on a system that's already under a great deal of pressure. We're trying to put something in place which ultimately will transform delivery and replace some elements of delivery, but whilst we get to that point, we're trying to do something twice. We're trying to carry on doing business as usual and introducing something new. And whilst, you know, the engagement is there, the interest is there, the desire is there, we've still got to do it on top of something else.
We've got another important strategic issue, which is about the financing of molecular testing. So whilst we do have a limited range of molecular tests that we routinely perform in the NHS at the present time, we know that there are many other things that we could be doing, and doing larger multi-gene panels or even whole genome sequencing is more expensive and is more complex, and we need to make sure that before we introduce new tests into routine NHS practice that they're properly tested and proven to be cost efficient and cost effective in terms of the overall treatment of patients with cancer.
We lead to a very big challenge of actually how within the NHS, in individual hospitals and GP clinics, clinicians and other staff will actually use this and be able to use it in a way that benefits patients. And I would suggest that that is probably the biggest challenge which faces the programme, because we're starting from a very low base. Not many people understand what this is about at the moment. There's growing amounts of publicity both in medical literature and in the popular press, but there's still a very large hill to climb just to raise awareness of where this is headed, and it's probably actually coming along the track really quite fast, and so this is something which is quite urgent.
One of the main challenges of the education side of things is changing people's perceptions of genomics now and how it might change mainstream medicine in the future. For lots of reasons, really. I think there's an element of fear from both patients and NHS workforce in terms of how it might change their current roles, how medicine is going to change and where they're going to fit into that future. But for the public and patients, it's about building up their confidence in terms of what this is going to mean for them, and to highlight the potential benefits that they will see, hopefully in their lifetime, but certainly in the future.
The scientists, doctors and nurses we spoke to described how genomic medicine is changing the ways they work together and the responsibilities for patients and families. They also discussed how their interactions with patients might change as genomic information comes through to the clinic and patients become more involved in decision making about the delivery of these initiatives. And they told us about how this brings with it new responsibilities for them as professionals and for the patients as they grapple with this new kind of information and its implications for cancer care. We will be exploring these issues in more depth, hearing from frontline professionals, patients and their families about their experiences of genomic medicine in the clinic and beyond.